Hello, I'm Luca Modenese from Imperial College London, and I'm presenting a work on the dependency of joint reaction forces on femoral geometry, and specifically femoral anteversion. My co-author in this investigation is Christopher Carty from Griffith University and the Children's Health Queensland Hospital. Generic musculoskeletal models are computational representation of the musculoskeletal system based on cadaveric and literature data. Here we will focus on lower limb models. It has been shown in the past that these models can accurately estimate joint loads at the knee and at the hip joint, and you can see here two studies where the model's estimation in gray and red were compared against in vivo measurement from instrumental prosthesis in black, finding good agreement. Generic models, however, are meant to represent an average geometry, and the effect of personalizing just a key anatomical feature to the anatomy of specific individuals or patients has not been fully explored. For example, one of these key features is the femoral version angle, the angle between the posterior condyle axis and the femoral neck axis, which is called anteversion if positive, like in this slide, and retroversion if negative. The effect of femoral version has been studied only at hip joint in patients with instrumental prosthesis and in children. In this presentation, we will investigate the effects of personalizing femoral version on all the lower limb joints. It is worth mentioning that it is currently challenging to personalize generic musculoskeletal models because there is a lack of freely available tools usable for this purpose. For example, the seam bone deformation tool used in several previous studies that you can see on the right is part of a commercial software product. In our study, we used the experimental data made available as the 5th Grand Challenge competition to predict in vivo knee loads. This data includes motion capture data, ground reaction forces, and most importantly, the recordings from a knee instrumented prosthesis during tasks performed by an 86-year-old male with a mass of 75 kilograms. For our study, we considered 5 overground walking trials. We linearly scaled a modified version of the full body model by Rajagopal et al. To the anthropometry of this subject and reduced the strength of the muscles crossing the knee by 40% to simulate the weakness due to the knee surgery, as previously done in the study by Mar et al. We called this model the nominal model. We also implemented the MATLAB toolbox for altering the skeletal geometry of generic musculoskeletal models. We modified the femur of the nominal model using this tool to apply a linear rotational profile that altered the proximal femoral geometry by increasing or decreasing the nominal femoral version, as you can see in the highlighted areas. The knee joint, as currently highlighted, was kept unmodified to decouple the effect of bone deformation from the kinematic model, which remained unaltered. This image gives you an idea of how the femoral geometry changed between 5 and 40 degrees anteversion. Please note that the muscle attachments were modified together with the bone. Using the bone deformation tool, we produced 6 modified models from the nominal model, with femoral version angle spanning from 2 degrees retroversion to 40 degrees anteversion, with a step of 7 degrees. This range was chosen following the report of femoral torsion angles available in Strecker et al. The femur of the nominal model was analyzed in NMS Builder and its anteversion angle estimated in 12 degrees. With the available 7 models, 6 modified models and the nominal model, we simulated the 5 considered gait trials using static optimization with a quadratic objective function for estimating muscle forces. Then, we computed and analyzed the magnitude of the resulting joint reaction forces at the lower limb joints, quantifying their peak variations and the accuracy of the knee joint loading against the in vivo measurements. I will show you the joint reaction forces estimated by the models for one representative gait trial. At the ankle joint, the force variations were less than 2%, suggesting that the femoral geometry did not influence them. At the hip joint, the effect of the bone deformation was evident. with joint reaction forces peaks being 6% smaller in maximum retroversion and 18% larger in maximum anteversion. A similar trend was observed for the knee joint, but in this case, the joint loading increase was larger, reaching 43% at 40 degrees anteversion. For this joint, we were able to quantify the accuracy of the predictions and identify the most accurate models. We found that the models with femoral anteversion between 5 and 12 degrees were the most accurate, and their simulations produced root mean square errors, a coefficient of determinations R squared, comparable with more sophisticated models in the literature. The peak error range was between 0.09 and 0.42 body weights, depending on the peak of interest and the trial. The most accurate models were also those presenting femoral version closer to the actual bone of the subject, estimated from the segmented computed tomography scans. Our findings demonstrated how bone deformation affects moment arms, which in turn modifies muscle recruitment and joint loadings. They also suggest that personalized femoral version could improve the joint reaction force estimation at the knee joint. Given the strong influence of a single morphological feature on the joint reaction force outputs, caution should be taken against using generic musculoskeletal models for personalized joint reaction force estimation, especially when the bony rotational profile differs significantly from the generic model. The conclusions of this study are limited by using a single participant, but the method is generic and can be applied to larger cohorts and other joints. Large bone deformation also caused alteration in muscle tendon lengths, up to 14%. That might require modification of the muscle architectural parameters. The models, results, and figures of this presentation can be easily replicated at home using the materials shared in the GitHub links. The bone deformation tool, in particular, is an open source and generic tool that you can use for your research. For example, you can apply a rotational profile to modify the distal femur, as in the figure on the left, or to apply a torsion to the distal tibia, as in the figure on the right. More details about the work I presented and all the relevant links to access the materials are available in this open access publication. I would like to conclude by acknowledging my colleagues and collaborators and all my funding sources. Thank you for your attention. I will be glad to answer any question you might have.